Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today, I'm going to give an overview of peritoneal dialysis, comparing and contrasting it to hemodialysis. But before we get into that, make sure you check out the other videos at this channel. Check out bcnephro.com where you'll find articles not only on this topic, but on a wide range of nephrology subjects. I'm also on Instagram at bcnephro. Links to all will be in the description below. But now, let's get into it. Dialysis is defined as the separation of particles in a liquid by a semi-permeable membrane. Clinically and medically, there are three things necessary for dialysis to occur. First is access to blood. Second is the semi-permeable membrane. And the third is dialysis solution, also referred to as dialysate. Now for hemodialysis, the access to the blood occurs through an arteriovenous access, fistula or graft, or a central venous catheter. The semi-permeable membrane is the hemofilter, also referred to as the dialyzer, and the dialysis solution, dialysate, is produced online using purified water mixed with an electrolyte bath. The three components are also required for peritoneal dialysis, and these occur with the peritoneal membrane, which lines the abdominal cavity, the peritoneum. The access to blood is the capillaries in this peritoneal membrane. The semi-permeable membrane is the peritoneal membrane itself, and the dialysis solution is sterile fluid that is produced and instilled into the abdominal peritoneal cavity. In both hemodialysis and peritoneal dialysis, the semi-permeable membrane allows diffusion of uremic molecules, urea and creatinine, as well as electrolytes down the concentration gradient, typically urea, creatinine, and potassium from the blood to the dialysate, and bicarbonate and calcium from the dialysate to the blood. There are, however, some differences. In both cases, this semi-permeable membrane is not permeable to red blood cells. They cannot fit through the pores, but the peritoneal membrane is permeable to protein, whereas the hemofilter is not. So patients on peritoneal dialysis may have some protein and amino acid losses. The other difference is the mechanism of fluid removal or ultrafiltration. Fluid can pass through a membrane by two mechanisms, either hydrostatic pressure or oncotic pressure. Hemodialysis uses hydrostatic pressure, and the precise amount of ultrafiltration can be prescribed, set on the machine very accurately. Peritoneal dialysis uses oncotic pressure. The oncotic pressure gradient is created by dextrose. There are high concentrations of dextrose in the peritoneal dialysis solution, and this works similarly to the concept of hyperglycemia. In a patient with severe hyperglycemia, the serum osmolality will be high, and fluid moves from the intracellular to the extracellular space to equalize that osmolality. Now, peritoneal dialysis solutions have varying concentrations of dextrose, 1.5%, 2.5%, or 4.25%, and the higher the concentration leads to more ultrafiltration. One problem with this is when the fluid is in the abdominal peritoneal cavity over a prolonged period of time, the dextrose can be absorbed into the blood, thereby diminishing this oncotic gradient and impairing ultrafiltration. For longer dwells, for this reason, there is another substance called icodextran, which can serve as an osmotic gradient and does not get absorbed into the bloodstream. Next, we're going to get into how peritoneal dialysis is performed. There are three components of peritoneal dialysis. The first is the fill. The dialysate is instilled into the abdominal peritoneal cavity via a catheter. The second is a dwell. The fluid is maintained for typically several hours, allowing for this diffusion and ultrafiltration to occur. And then after a period of time, the third component is the drain. The dialysate is drained and discarded, and at that point, the cycle can begin again with a new fill. Now, this can occur either manually by manual exchanges and drains, or automated through a machine called a cycler. The manual regimen is referred to as CAPD, continuous ambulatory peritoneal dialysis. Typically, there are 4 exchanges that occur in the day, typically every 4 to 6 hours during the day, and then a longer dwell overnight. When it is done through the machine, it is referred to as CCPD, continuous cyclic peritoneal dialysis. For CCPD, a machine automatically does typically in between 4 and 6 exchanges in between 8 and 10 hours overnight while the patient sleeps. At the end of this cycle, there often is a end fill that is maintained during the day and drained in the evening when the patient begins the machine again. Sometimes the patients only get the peritoneal exchanges overnight and they do not have any fluid in their abdomen. It's referred to as a dry day. This technically is referred to as NIPD, nocturnal intermittent peritoneal dialysis. Why do peritoneal dialysis? Which is better, peritoneal dialysis or hemodialysis? Now, from a mortality perspective, they're considered equivalent. There might be a slight mortality benefit with peritoneal dialysis over the first several years. This, however, dissipates over time. So patient preference is a main factor. I'm going to go over some of the pros and cons of peritoneal dialysis versus hemodialysis. One pro is that residual kidney function typically is maintained longer with peritoneal dialysis than hemodialysis. The hemodynamic strain with hemodialysis typically causes the residual kidney function to be lost sooner. And residual kidney function is important. Dialysis does not do everything the kidneys do. Every bit, even a GFR of 5 mLs a minute, is important and helps the patient. Second is independence and flexibility. The prescription can be modified, particularly with the overnight cycler, to allow the patient to do other things, work during the day. Third is peritoneal dialysis is less prone to induce hypotension. So some patients who cannot tolerate the ultrafiltration with hemodialysis who develop hypotension may be able to tolerate peritoneal dialysis. Fourth, bacteremia is very rare with peritoneal dialysis. Now, there may be infections that can be severe, such as peritonitis. However, bloodstream infections are quite rare. So in a patient in whom bacteremia can be even more severe, let's say a patient with a mechanical heart valve who could get prosthetic valve endocarditis, there would be a decreased risk of bacteremia in this with peritoneal dialysis as opposed to hemodialysis. And then finally, typically, there are less dietary restrictions with peritoneal dialysis. Some of the downsides of peritoneal dialysis are, first, it is less efficient than hemodialysis. So it typically needs to be done daily or at least nightly, 7 days or nights a week, as opposed to just 3 with hemodialysis. Given the decrease in efficiency, the residual kidney function is often important or necessary to maintain this as a reasonable modality. Patients who lose residual kidney function may not be able to perform enough peritoneal dialysis to prevent uremic symptoms. Also, there is the responsibility for the self-care. With the freedom and independence come responsibility. You can't have it both ways. Okay, finally, I'm going to get into some important things to remember, some pearls about peritoneal dialysis. The first has to do with the residual kidney function, which is very important and often necessary to maintain peritoneal dialysis as a modality. So in this case, you would need to be careful when prescribing a nephrotoxic medication or giving intravenous contrast. You shouldn't have the mindset that they're on dialysis anyway, so I can't hurt things. So before doing this, particularly in peritoneal dialysis, you would need to make sure there is no residual kidney function and weigh the risks and benefits. Second is patients on peritoneal dialysis actually are prone to hypokalemia. The potassium is removed efficiently with peritoneal dialysis, and unlike hemodialysis where they get hyperkalemia, patients on peritoneal dialysis often require potassium supplements. Now, there is a way to instill potassium into the peritoneal dialysate fluid. However, there's some pitfalls from this, and it is typically preferable to give oral potassium supplements. The third thing has to do with the protein losses in the peritoneal dialysis and amino acid losses. Up to 6 to 12 grams of protein can be lost daily, so there is a high incidence of malnutrition, and attention to diet, including supplements, is typically necessary. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Leave a comment, a question you have about peritoneal dialysis. Please share this video with someone who you think might want to learn about PD. It's spreading the message word of mouth that really helps the channel grow. And until next time.